teaching program, and he organized so many conferences and workshops, and he has a number of publications, and he has more than 2000 citations and publications in high index journals. I request Deepak Talwar sir to take the.
Good afternoon, everyone, and thank you very much, Lokesh, for having me today here. And I was thinking that a lot of people have got little uncomfortable topics, and I was looking at Rajni, how he was doing so much of justice to this. I saw even Raja doing a lot of justice to this thing. Thank God I was not introduced as an interventional pulmonologist, because I'm not. And but yes, we got the e-bus second in India, which was in 2012, and within 6 months of it being operational, my consultants threw me out of the bronchoscopy suite and told me that you are now old enough to get into the other things rather than letting us do all these things. And I'm very happy, because I think 4,000 e-bus they have done. So I'm very, very happy that I was out of it. Topic which has been given to me is sarcoidosis, and I think Lokesh has put a lot of words into it: invisible invader, and diagnosis, treatment, and triumph. I think it's a long journey basically for sarcoidosis for us, definitely, and primarily because since 2016 we run the Vasog sarcoid clinic in our Noida. And we have contributed to almost about 8 to 9 publications in Vasog and various other journals through this. And very happy that we picked up sarcoidosis and tried to learn for it. And so I think this is a uniform slide. Sarcoidosis is an enigma. No two patients look alike. It's a heterogeneous disease in its presentation, which we all know, but also, what happened? It got disconnected. Trying to say is it's not only in its presentation it is heterogeneous, but it is also equally heterogeneous when it comes to how it evolutes in an individual patient's, their response, and very important, progression. Everything is not same and similar in various kind of patients of sarcoidosis. But let's see some statistics and keep that in your mind when you see a next patient of sarcoidosis. And that's like this: 90% of sarcoidosis patients will have pulmonary involvement, but most of them will resolve in 2 to 3 years. Most of them will resolve in 2 to 3 years. Only 20% will develop fibrosis, and out of those 20%, only 10%, 1/10 of them, will progress in fibrosis. And ultimately, of all the sarcoid patients we diagnose, only 6% die early. So their life expectancy is reduced only in 6%, and when they die, 70% die because of the lung involvement and lung-related mortality. And it's now reported 10% is hereditary. So this heterogeneous disease has been very frequently misdiagnosed in India, and we all know about it. There is nothing to talk about it, because 30% gets misdiagnosed as tuberculosis and take their treatment of tuberculosis, but 15% of them are misdiagnosed as sarcoidosis also. And the follow-up data suggests that 5% patients of sarcoidosis on follow-up will develop tuberculosis. That's nothing great after Rajni has told us that how much of tuberculosis is going on in our country. So it is accidental, incidental, I will not comment on that even, but if they do develop, it's okay. But if they develop within first 6 months, we start doubting our diagnosis that whether it was really sarcoid or we missed the tuberculosis completely. Data which we published showed that, even if you have a clinical picture, you have a radiological picture, you have a histological diagnosis, nearly about 3/4 of the times you will be correct in making a diagnosis of sarcoidosis. And you really need an MDT team to improve your accuracy to make the diagnosis of sarcoidosis. Now that's the problem, because the presentations of pulmonary sarcoidosis are protean. It can present with anything and completely non-specific, which may have nothing. So it may be asymptomatic or accidental, constitutional symptoms, respiratory symptoms, systemic symptoms, and infrequently or more frequently, examination doesn't tell us anything. And it's a disease which is characterized by relapses and recurrences. Blissfully, the relapses and recurrences do respond to treatment and they spring back to their normal lives back again. So I'm only going to cover a little bit of diagnosis of sarcoidosis, and I think everybody will agree that the moment we talk to the patient that your diagnosis is sarcoidosis, there is some uncomfortability in that communication, because inside yourself you are not 100% sure that it is sarcoidosis, and the poking questions, direct poking questions of the patient are always to the point, 100% sure, and then nobody is 100% sure, because diagnosis of sarcoidosis is a retrospective. So after 2 years or 3 years, I can say, yes, you definitely had sarcoidosis, but as of date today, very difficult. What helps us to make the diagnosis? We use biomarkers, we use imagings, we use pathology. Everything is non-specific and non-sensitive. We are reporting normal X-rays, we are reporting normal lung functions, we are reporting bronchial asthma pattern of reversibility, we have non-caseating granulomas which has got 20 other causes, and where do we fit in basically? The diagnosis itself neither sensitive nor specific. We a lot of time use serum angiotensin converting enzyme. I think it's a routine, we write it, and we are just not able to get over it that it is non-specific, and definitely it is non-sensitive. So there is nothing, no specificity, no sensitivity. So it's up to 2 times actually you can just discard it. Don't even consider it is of anything. And of course many other things are there, but if it does anything, it is basically of prognostic value. So it might be showing some improvement with lung functions on treatment. That's what it does. And if it's like less than 100, I think don't even look at that report. And that will be like, I think almost 9 out of 10, or even maybe 9.5 out of 10. So not a diagnostic one, but it's okay. It's made by the macrophages and the granuloma. It's okay, fine. Vitamin D metabolism is again one of the biomarker which we try to look at it. We try to look at serum calcium. We'll try to look at calcium in the urine. And nearly 40% of sarcoid patients may have hypercalciuria, but also the patients who are on vitamin D supplements will have hypercalciuria. And what we need to do is actually 125 dihydroxy vitamin 3, D3, which we generally don't do. And this is the biggest mistake which happens in practice, that you do a vitamin D3, it is low. You start with vitamin D3 and calcium, and these patients develop hypercalcemia, acute kidney injury, and they come up into the intensive care units with hypercalcemia. So always do 125 dihydroxycholecalciferol, and if that is low, then cautiously replace it with vitamin D as well as with calcium. Otherwise, there is no need even if vitamin D3 is low in these patients. But they all indicate activity, and again, they have no role to play, because there are other similar overlapping causes of vitamin D calcium metabolism disorders, including tuberculosis. So it doesn't make a difference for us if it comes like raised and we say, okay, this is sarcoid. No, we won't do that actually. Then comes our X-rays and CT scans, and you all know that how confused we become. Number of signs have been told about it, and we have all grown up with learning these beautiful names, and we would like to, teach our postgraduates with all these things in our daily practice. But so-called as beading sign of the interstitial involvement of sarcoidosis at the fissures itself is not diagnostic of sarcoidosis. So it doesn't make sense It gives you maybe a little feeling, but it does not help you to make a diagnosis of it. But yes, now this beyond the radiology and CT scans, we are actually now moving, and we are leaving that stage 1, stage 2, stage 3 completely to the severity of sarcoidosis, because what will kill the patient of pulmonary sarcoidosis is a severe pulmonary sarcoidosis, not on the radiological stages, because even stage 4 disease or stage 3 disease, people can lead normal life without any reduction in their expectancy of survival. EBUS came, as I told you, 2012, so I was overjoyed that, blind TBNAs don't have to be done, and you have got something to look into it, and you will be able to do biopsies. But same year in chest, PGI did show this data that they were doing TBNAs blind at that time, and they were quite well, and they showed that blind TBNA versus EBUS TBNA, the results are nearly the same. But what's the important thing in this study was that if you combine sampling of the lymph node with the sampling of even normal looking endobronchial mucosa as well as a transbronchial biopsy of the lung, you have a reasonable level of confidence in making the diagnosis of sarcoidosis to the tune of about 80 to 85%. And the recommendation from that onwards was that whenever you do EBUS or you sample the lymph node, please take an endobronchial biopsy. It doesn't matter if the mucosa looks normal. And also combine it with a transbronchial lung biopsy. Even if the CT does not show that lung is involved, you will get granulomas on the transbronchial lung biopsy. Things moved further, basically, that we tried to add cryo now, and I have seen that beautiful video which Lokesh has shown us, that cryo is being used for lymph node, it is used for the lung, perfectly right. And obviously now surgical lung biopsy in sarcoidosis is hardly ever done, so that 100% thing is almost achieved with the transbronchial cryo lung biopsy. And we went ahead and also did a cryo endobronchial mucosal biopsy, whatever is the look of the mucosa, and tried to combine it in the data form. And you can see that this is going to be presented in VSOC this year, that if you do a cryo EBB and an EBUS, your results are as good as if you do a blind mucosal punch biopsy, EBUS, and a transbronchial lung biopsy. So what does it mean? That you can get away without doing a transbronchial lung biopsy, which most of the pulmonologists in the periphery would not like to do, because they think that, they'll get the answer in the EBUS, but one granuloma never gives the answer. If you have two sites showing you a granuloma, your diagnostic confidence in making level of confidence in making a diagnosis of sarcoidosis increases significantly. So once the granuloma comes, the challenge actually begins. It's a granuloma challenge, because it's a pathologist problem now. They have to rule out at least 20 causes, out of which 10 are common in India, and some of them they can never rule out. So that's very, very sure. So that is where actually we are having a Waterloo, that we are not able to conclusively exclude all the causes of granuloma, and conventionally, or rather the diagnosis of sarcoidosis requires you to rule out all other causes of non-caseating granuloma before labeling it that it is a sarcoid granuloma. There are many people who do reticulin stains in the lymph nodes and they say fibrosis is there, so it is sarcoidosis. Why not talc can do that? Why not so many other exposures can do? So BAL biomarkers, we all do that BAL lymphocytosis, and you know that more than 15% has a sensitivity of about 68%, and it is non-specific. So never stop at BAL lymphocytosis. Then we started doing CD4, CD8 ratios, more than 3.5. Again, if you look at the sensitivity and specificity, it is low. CD103 is again one of the new marker with the ratio of CD4 has been done, and the ratio of 0.2 and above is again considered, but these are all non-specific and non-sensitive. There are many other things in the future which is going to come, but nothing is going to be so bright that it is going to sort out our problem that this is for sure sarcoidosis as far as India is concerned. So we looked into this multi-continent data that can we develop a diagnostic score for sarcoidosis patients, and this kind of diagnostic score can be of two types, one clinical and one biopsy based. And we have set of questions and you put it into them and you get the number. And what we found was that without biopsy, the STS score, clinical, if you have a number reaching 4 and above, almost 90% chances are that your diagnosis of sarcoidosis is correct. It was published in ATS journal. It's a wonderful article. If you want, you can read that. But it's eye-opener that still, because I think a lot of patients were recruited, not only from the America and Europe, but it was also from China and India. So we are left with after a diagnosis, which is not very sure, little uncomfortable, talking to the patient not so happily as you would do with tuberculosis. You know that it is non-caseating granuloma, patient is MON2 negative, patient is having constitutional symptoms, patient has lymphadenopathy, and inside you are not very sure that it's like, I'm 100% sure it is sarcoidosis. So treat or not to treat? That's the question which is forced on. And the most important thing in sarcoidosis is that the traditional treatment algorithms, which has been used in the medical literature for the management of sarcoidosis, uses a approach which is called one size fits all. Diagnose sarcoidosis, give steroids. That's all. That's how it has been done. And it has led to so much of over-treatment and steroid-induced toxicity as a comorbidity coming up in sarcoid patients, which actually kills more people and gives more morbidity rather than the disease itself. And here we are hanging actually, between mortality risk due to sarcoidosis, morbidity risk because of the sarcoidosis, vis-a-vis over-treatment causing toxicity. And you really need to make this balance correct in your real practice. And your question will be, how can we do that? How can we do that? So we'll tell you that this is again the data from 4 continents. And obviously the Noida center is ours. You can see that 90% of the patients get some treatment for sarcoidosis. Only to match is Cincinnati. So definitely we are all over treating sarcoidosis. We need to have an algorithm where we should understand that when to treat and when not to treat. So for that we need to understand these 4 things which are in the natural history of sarcoidosis before you jump to take a call ki mujhe isko treat karna hai, I'm going to treat this patient. Sarcoidosis can regress spontaneously with or without treatment. Can become chronic, can develop exacerbations, can still have remissions after getting exacerbations and good response to treatment. All these things are good things which we must keep in our mind. And if we look at the numbers, half of the patients of sarcoidosis, pulmonary sarcoidosis, will resolve without treatment. 2/3 will achieve remission in 10 years. And half can be considered cured of sarcoidosis in 12 to 36 months. So it doesn't look that bad disease which I painted in the initial part of the journey. But the biggest question which is unanswered is we do not know which patient of sarcoidosis sitting on day 1 in front of us is going to become bad in future. That's the risk analysis which is just not there right now with us. So a lot of people have been working on it, but one thing is clear, that major organ or major organs involvement means that worse outcomes. You need to treat them. And nearly 30%, 1/3 of patients of sarcoidosis only do have major organ involvement. So I think the message should go that only maybe 1/3 patients actually require to be treated, not all of them. Maybe some of them will be the fence sitters, so at least I will say 50-50 will be good enough. But one thing is again a very important data, that those patients who require treatment for sarcoidosis, oh, it's gone again. Sorry. So those patients who require treatment for sarcoidosis within 3 months of diagnosis of sarcoidosis, they have nearly 3-fold higher mortality in comparison to those patients who did not have any trigger factor where the steroids needed to be started in this group of patients. Okay. I think I am disturbing it every time and battery. Yes. So those of you who have visited me and seen me in our center will see this book of Sarcoidosis on my table all the time, because this is the inspiring book to tell you how to have your principles in place when you are deciding about the management of sarcoidosis. And for that we need to remember this person. I do not know how many of you recognize him. He is Athol Wells. And he has what is called as Wells' law. And this Wells' law is the one which is practiced in almost all good sarcoid centers, including ours, that you need to treat the patient of sarcoidosis, you need to fulfill 3 criteria. Number 1, your diagnostic certainty should be of high level. You have excluded everything. That's what we discussed. Second, there is threat to life of the patient. And threat to life comes from the major organ involvement only. Not with the mediastinal lymphadenopathies, which gets treated with steroids, which actually don't need any treatment at all, just symptomatic treatment. And that's the threat of life, which is very important for the lung perspective, where lung functions with the FVC of more than 70% and DLCO of more than 60% is called safe zone. You can leave them, even if they are stage 2 lung involvement, nothing. You can leave them on observation, unless and until there is something else which troubles you there to make you more uncomfortable to treat the patient. And very importantly, quality of life is invariably ruined in sarcoidosis because of fatigue. And you can't do anything about fatigue actually. So you try to give them something to make them feel better. Obviously, we keep telling them run, do rehabilitation, physiotherapy, all those things, but nothing works there. So now what we do in pulmonary sarcoidosis is we assess their severity. And what are the tools for the assessment? We have symptoms, we have 6-minute walk test, we have pulmonary functions which should include a diffusion capacity, we have imagings, we have disease behavior, and we have of course surveillance of physiology as well as a response to treatment over a period of time which tells us which way the patient is going. All these are very important. Now this is a very recent paper on CT phenotypes of sarcoidosis. So this is a Delphi consensus statement. We are also part of it. It's done by the Brompton group again and published in Lancet Respiratory. So what was the idea was trying to find out what CT patterns, if you see on a sarcoid patient, will tell you that these patients are not going to do good, you need to treat them. I think that's exactly the question which was very well addressed. That is what we want to know. So they divided it now into fibrotic and non-fibrotic sarcoidosis. So lung changes are either fibrotic or non-fibrotic. So all those nodules, this, that, what we said, all those things what we see in sarcoidosis are actually all non-fibrotic. And these 4 patterns which you see here are the fibrotic patterns. You can see that there is a traction bronchiectasis, there is a traction bronchiectasis with honeycombing, there are cavities fibrocystic with aspergillomas, and there are masses. So these 4 group of fibrotic CT phenotypes of sarcoidosis are considered by the consensus. So once we need to treat a patient of sarcoidosis, I need to ask my question that is that patient at high risk of having morbidity and mortality related to sarcoidosis or at low risk? Because at low risk, I will be having a different strategy vis-a-vis when it is at high risk. So how do we do that? So this is again what I am trying to show is the CPI score, which includes the physiological as well as clinical parameters, which includes diffusion capacity and FVC. And this is again devised from the studies which have been done at Brompton, that if you have a CPI score of more than 40, you are at high risk to have complications of sarcoidosis related to morbidity and mortality, and you need to treat them. If your score is less than 40, you look at now the CT scan. If the CT scan shows that the fibrosis is more than 20% with this kind of CT phenotypes, or the diameter of the pulmonary artery / aorta is more than 1, is considered as again a high risk factors and put the patient into high risk group where you need to treat. But if they have nothing, CPI less than 40 and nothing else is happening, so this is fine, the CT is fine, don't need for treatment. So what is a clear danger in sarcoidosis? You all get lung function tests. So you should be able to see the report and say that there is a danger. And that danger is when the FVC is less than 60% and KCO is less than 60% and DLCO is less than 40%. So if you get these three values or any one of these three values in your PFT report of a patient of pulmonary sarcoidosis, it's a clear danger, means we need to really treat them well. Because this CPI score of 40 correlates with survival. So it has been shown that if you have more than 40 CPI score, your probability of surviving 6 years is going to be reduced to like 50%. That's the mortality risk, and it is on the basis of the CPI score. So how do they die in sarcoidosis? Even if in pulmonary sarcoidosis, how do they die? They die either because of the respiratory failure or because of the cardiac event. And that could be heart failure or arrhythmias, and it's mostly related to cardiac sarcoidosis, which has never been discovered, and pulmonary hypertension. So coming to the treatment part, what is the first line therapy? We all use steroids. We know that. First line therapy, steroids. So if you are in the low risk, which is about 70% of the patients, actually they just need observation and little bit of counseling and monitoring. And if they deteriorate, obviously steroids, but if not, which is most likely going to happen, these patients are going to be free of steroids for God knows, they get into remission. 30% will require, which are like high risk or in the intermediate risk, but there is a impaired quality of life. You use steroids in that. The next question comes, how to give steroids and how much to give steroids and for how long to give steroids. That's the $1 million question, because everybody has his own approach. Somebody gives 10 mg, somebody gives 20 mg, somebody gives 30, 40, 60, 80. All mg strengths are being used in sarcoidosis. Now 10 mg is given for quality of life, where you decide with the patient that he's so troubled, you are very convinced that this patient does not need steroids, but now his cough is not going, he's troubling like anything. Okay, so that is the dose which will have less toxicity to the patient as well as to the treating physician, because he is agreed that 10 mg is good enough, and it will be titrated according to the patient's symptoms, quality of life improvement. Now comes 20 mg versus 40 mg. So between 40 to 80, the data already showed it makes no difference, so don't go to 80, please stick to 40. Between 20 to 40, the PGI group SAGEL published in this Sarcod trial, and they presented in last year in the ERS, that whether you use 20 or you use 40, it makes no difference at all. So please use 20 milligrams of prednisolone rather than jumping to 40, 60, 80. I think you can ask me that per kg how much it should be, like if somebody is 80 kg or something. I will still like to be between 20 to 25 only. I will not jump the dose of steroids even in those cases, because steroid-induced side effects, I will show you a slide. Now, when do we add second-line therapies, and what are those second-line therapies? So second-line therapies are used for one main reason, that you don't want oral corticosteroids because they are causing toxicity. Every time you try to bring the dose down, patient is becoming bad, and now you need to increase the dose of steroids, start using second line. Other is that OCS side effect burden is so much on the patient, you need to use the second line alternative therapies. Or if the patient relapses, so you gave steroids, you stopped steroids, patient relapsed after some time, now at this time you have to use a second line therapy. What are those? Most commonly is methotrexate. You can, if the patient doesn't tolerate methotrexate, the dose is between generally around 15 milligrams. You may go up to 20, but most of the patients, if with steroids, even 10 mg of methotrexate is good enough. But if you are tapering down to 0, then you might have to keep between 15 to 20, which is a very comfortable dose. If patient is not tolerating, azathioprine. You can use leflunomide, and now people are using MMF, although I am not very big fan of MMF, and hydroxychloroquine only. If they have skin sarcoidosis, they have joint symptoms, you can use that. Can HCQS reduce the oral steroid dose also? There is one study which Randeep published which did show that actually it has some salutary effect to help you to bring down the dose of steroids in patients with sarcoidosis, but that's the only study. What if patient fails on these two therapies, that is steroids and the methotrexate or MMF or azathioprine, whatever it is? Now you have an option of what is called adalimumab and infliximab. So I think it was a lot of discussion about rituximab causing tuberculosis. So everybody in India is scared of using infliximab and adalimumab. So we published, I think 4 years ago, 9 case studies of sarcoidosis together in whom we used infliximab, and we didn't get any tuberculosis. But after became more happy to use it, we did get one patient like that. But 1 out of 14, 15 patients, that's the normal thing in tuberculosis which is going to happen. But how much of improvement in quality of life it did, because they were either not tolerating or failing on second line therapy. So I will not stop using infliximab and adalimumab. Adali can be given in the OPD itself. They don't have to be admitted for that. And they have even given the last line, that is the 4th line therapies, that is rituximab and JAK inhibitors. I have not used it so far. And this is the steroid toxicity in sarcoidosis. So patients who receive steroids, the toxicity is related to cumulative dose and how long you have used the OCS. So beyond 6 months, the group of patients who got steroids and the group of patients who did not get steroids, there is a 2-time risk of cumulative toxicity endpoints, which is diabetes, hypertension, weight gain, hyperlipidemia, low bone density, and eye complications. So all of them are the primary composite endpoint related to toxicity of steroids. That's why there is so much of change in thinking that how to keep the dose of steroids, cumulative dose, low. And for that now the new, the approach in sarcoidosis is hit hard early rather than stepping up. Not that give steroids, then give second line, then go 3 lines. So if you think your patient has got severe sarcoidosis, pulmonary, upfront start steroids with second line therapy, which is methotrexate. If your patient is really bad, like he's progressive sarcoidosis, he's cardiac sarcoidosis, spinal cord sarcoidosis, upfront 3 therapies, and the 3rd therapy is infliximab along with it. So we have used infliximab as in the triple therapy in a couple of patients, and particularly in very bad lupus pernio, it does wonders to these young ladies who look horrible with those kind of scars on their faces. It does wonders to them. So we use it in that as well as cardiac sarcoidosis as well as advanced pulmonary sarcoidosis. So I'll conclude here that you really need a high level of confidence in making a diagnosis of sarcoidosis. Otherwise, it is retrospective. CT phenotypes is something which is going to come up, and I'm sure when it is added with AI, it will help us much more. Multimodality severity assessments is a must, and it must be periodically done again and again to see that patient is going stable or he is now declining and you need to intervene and start the therapy if it was not given before, or if it's a relapse, you restart the therapy. Loading steroids is no longer an option at all, and if at all the patient has severe sarcoidosis, early initiation of dual therapy is something which we are talking about, combination therapies, and this is the future for the sarcoidosis at the moment. And if you want to learn more about sarcoidosis, then this is the right thing where you should be. That is WASOG in India, first time. Be at Agra and attend this 3 days meeting. You will have plenty of learnings from perhaps the best minds in sarcoidosis. Thank you very much.